Hello, my name is Julia Klein, and today I'm going to be presenting my case study on pneumonia for nursing 20005. So let's begin with a typical pneumonia patient. Mr. Respiratory is a 72-year-old Caucasian male who presented to the ED with the following signs and symptoms: a productive cough with green-brown, sometimes rust-colored sputum, dyspnea, pleuritic chest pain, fever, and general malaise. So he reported that he had initially experienced a non-productive cough, then escalated into a productive cough with sputum over the past few days, and was also accompanied. Mr. Piratori's history includes chronic obstructive pulmonary disease, congestive heart failure, and rheumatoid arthritis. He has been a smoker most of his life, currently smoking 2 packs a day and drinking approximately 3 standard drinks each night. He is currently taking methotrexate for his rheumatoid arthritis, metoprolol, amlodipine, tiotropium, and salbutamol. So upon clinical examination, Mr. Piratori's findings were as follows. He was febrile at 38.1 degrees, his pulse was high at 105, his blood pressure was 110/78, his respiratory rate was high at 24, and his O2 sats were sitting at 86%. However, the patient did state that 88 to 90 was a normal range for him considering his COPD. He reported stabbing pain 7 out of 10 in the pleuritic area. His GCS was 15 with NAD there. Upon a focused respiratory assessment, it was found that there was significant work of breathing with increased use of accessory muscles. Dullness was noted upon lung percussion, and rhonchi was heard upon auscultation of lung lobes. A full blood exam revealed an elevated white blood cell count, and the chest x-ray showed obvious areas of consolidation. Here is a typical x-ray of a pneumonia patient. You can see there the areas of consolidation. I've also included a YouTube link to typical rhonchi lung sounds that are heard in pneumonia patients. So let's dive into the pathophysiology of pneumonia to find out what is occurring with Mr. Piratori. So pneumonia is broadly defined as an infection of the lung parenchyma, primarily caused by bacterial, viral, or fungal respiratory pathogens. This infection causes the alveoli to fill with fluid or pus. Pneumonia is associated with alveolar edema and congestion that ultimately impair gas exchange. Can be subclassified into types based on the method of acquisition. So types of pneumonia include community-acquired pneumonia, which is pneumonia acquired outside of the hospital, and nosocomial pneumonia, and these pneumonias are acquired in the hospital settings. Under this fall both hospital-acquired pneumonia and ventilator-associated pneumonia. As mentioned, pneumonia can either be caused by bacterial, viral, or fungal respiratory organisms. These pathogen types differ depending if the pneumonia is community-acquired or nosocomial. I have included for reference the common types of pathogens that can cause pneumonia for both community-acquired and nosocomial pneumonia. These respiratory pathogens are transmitted from person to person via droplets or, less commonly, aerosol inhalation. Following inhalation, the pathogen colonizes the nasopharynx, reaching the lung alveoli via microaspiration of oropharyngeal secretions from the trachea. However, the lower airways do have defense mechanisms to avoid invasion of the alveoli, so an innate or acquired defect is required to initiate pneumonia. Predisposing factors for this aspiration include impaired mucociliary clearance and immunosuppression. Once it reaches the alveoli, replication of the pathogen and the production of virulence factors occur. This triggers the host's immune response, leading to an inflammatory response. Alveolar macrophages are the predominant immune cell which respond to lower airway bacteria. However, a stronger immune response comes into play when an overwhelming virulent pathogen causes these alveolar macrophages to recruit neutrophils. These neutrophils are recruited to phagocytose and engulf the bacteria. The alveolar macrophages release cytokines and interleukins. These factors promote neutrophil movement or chemotaxis and maturation. The leakage of the alveolar capillary membrane due to cytokines occurs, with the end result being inflammation of respiratory tracts and alveolar edema. This is what bacterial pneumonia is. Bacterial pneumonia has four classical stages of inflammatory response. One is congestion. This is microscopically characterized by vascular engorgement and intraalveolar edema. Many bacteria and few neutrophils are present. Stage 2 is red hepatization. So the presence of erythrocytes are in the intraalveolar exudate. There is a neutrophil influx and bacteria is seen in specimens. It's microscopically marked by the cellular exudate of neutrophils, with some showing ingested bacteria, also marked by the extravasation of erythrocytes. Fibrin within the alveoli are seen. 3 is grey hepatization, so this is when the fibrinopurulent exudate is present. What this involves is progressive disintegration of red blood cells, with neutrophils being predominant here. Finally, resolution. So there's a gradual restoration of pulmonary architecture that begins to occur. Enzymatic action begins centrally and spreads peripherally. This liquefies the previous solid fibrinous content and eventually restores aeration. Macrophages are the predominant cells containing engulfed neutrophils and debris. I've included here a visualization of these four stages. The signs and symptoms Mr. Puritori is experiencing, along with his clinical exam findings, all relate to the underlying pathophysiology of pneumonia. Let's see how they relate. So the productive cough with sputum indicates presence of secretions in respiratory tracts due to aforementioned inflammatory response. Fever similarly is due to the inflammatory response, as in inflammation, pyrogenic cytokines are released which stimulate fever production. Pleuritic chest pain is common, as pneumonia frequently involves peripheral lung and quickly spreads to the pleura. Dyspnea is caused by impairment of alveoli function, which impairs gas exchange, and also presence of pain. Increased heart rate may be due to pain, and tachypnea may be due to a combination of attempting to achieve higher oxygenation and also pain. Low oxygen sats due to impaired gas exchange caused by altered alveoli structure and function, and dullness on percussion and rhonchi on auscultation due to the presence of consolidation. The elevated white blood count, of course, indicates a response to infection. There are various complications that may occur as a result of pneumonia. It can potentially lead to respiratory failure due to the impairment of gas exchange between the lungs and blood. Respiratory failure is a syndrome in which the respiratory system fails in one or both of its gas exchange functions, these being oxygenation and carbon dioxide elimination. It is, of course, life-threatening. A goal here is that the patient will demonstrate improved ventilation and oxygenation of tissues, as evidenced by arterial blood gases within the patient's acceptable range by 24 hours. They will also maintain absence of respiratory distress symptoms during the hospital stay. Nursing intervention 1 is to position patient in the semi-Fowler's position as tolerated. So the rationale behind this is that the studies have determined that semi-Fowler's position promotes maximum diaphragm expansion, which in turn can increase oxygen saturation and can relieve dyspnea. Second nursing intervention is to encourage and demonstrate deep breathing and coughing exercises hourly. The rationale behind this is that it mobilizes and allows for the expectoration of airway secretions, leading to improved alveolar ventilation. The expected outcome of these interventions is that the patient will achieve and maintain optimal ventilation and tissue oxygenation. This may be evidenced by the patient's ABGs, rest rate, and O2 sats remaining within normal limits, and also the absence of respiratory distress symptoms. A second complication is bacteremia due to pathogen presence. Bacteremia is defined as the presence of viable bacteria in the bloodstream. This occurs when the immune response fails to control bacterial spread due to inherent or acquired immune defects that are associated with susceptibility to infection. This can be life-threatening and quickly lead to sepsis. The goal here is that the patient will demonstrate timely healing of infection, experience reduced purulent secretions, and be afebrile by 48 hours. So nursing intervention 1 is to administer indicated prescribed antimicrobial medications, adhering to a rigorous schedule, and monitoring the effectiveness of this therapy. Rationale behind this is that early initiation and timely administration of antibiotics with adherence to a determined dosing schedule leads to faster healing of infection and reduced mortality. Nursing intervention 2 is to monitor and promptly report any sudden changes in condition and signs and symptoms of bacteremia. These signs and symptoms include increasing chest pain, recurring fever, chills, or changes in sputum characteristics. The rationale behind this is that early detection and reporting of these signs and symptoms can ensure early treatment and again reduce mortality. The expected outcome of these interventions is that the patient will continue healing from pneumonia without the complication of bacteremia arising. This can be evidenced by a reduction in secretions, reduced white blood cell count, diminishing symptoms, and achieving an afebrile state. I have included here all my references, including the in-text references on the PowerPoint and also the references I have used in my expanded voiceover information.